Okay, so now we're ready to start, and so it gives me great pleasure to introduce Nina Thomas, who is going to present today on PCORnet, which is an overview of the national healthcare database that Ohio State is, and she'll give more details about this, but it's basically like a partnership sponsored by Pcori, where we bring the other, healthcare data from different universities into one kind of common format. So it's very cool, and I'm hoping that we'll get kind of excited about what the possibilities bring from this data set. And without further ado, I'm gonna hand it over to Nina. So thank you very much, Nina, and the ball is in your court.
All right, thank you, Guy. All right. So good afternoon, everyone. My name is Nina Thomas. I'm a senior BMI consultant in the Department of Biomedical Informatics, and I'm also the project manager for the PCORnet Consortium at Ohio State. The PI for the PCORnet Consortium at OSU is Dr. Soledad Fernandez, who is the vice chair of BMI and the director of Center for Biostatistics. So what I'm going to do is, today I'm going to give you a brief overview of the national healthcare database called PCORnet. We have broadly classified today's session into 5 sections. Are you guys able to see my screen move?
So did you try to advance the slide?
Yeah, I did.
Did you already
it's not.
advance?
Yeah, let me see if I can.
Now it advanced.
It did. Okay. All right. Good. So what I was saying was we have broadly classified this into 5 sections. That includes the network. We'll provide a brief description of the network. Then we'll go into detail about the data that is available in PCORnet, how this data is structured into what is called the common data model, and how you can request this data for your research purpose. And we will also go briefly into the scope of use and the significance of a network like PCORnet during this, during the era of COVID, during this pandemic era. So let's start with the network and see how it is structured. So to understand it better, I think we'll begin with the parent organization, that is Pcori. Some of you might be familiar with Pcori or might have heard about Pcori funded studies or research. For those of you who have not, what is Pcori? Pcori is the Patient-Centered Outcomes Research Institute. It is an independent, non-profit, non-governmental organization in Washington, D.C. that was authorized by Congress in 2010. The main idea behind establishing it was to fund research that can help or improve the quality and relevance of evidence available to help patients, caregivers, clinicians, employers, insurers, policymakers, everyone to make better informed decisions about the healthcare choices they face every day. So the first 4 letters of Pcori are PCOR. It is a type of comparative clinical effectiveness research, or CER. CER is basically, it is a research that identifies what clinical and public health interventions work best for improving health. So interventions, they not only include the elements of direct clinical care, such as diagnosis or treatment protocols, but it could also be innovations in healthcare delivery, organizations and financing, as well as public health interventions in the community, including some of those that are intended to modify health awareness, lifestyle, diet, or environmental exposures. These all are included in CER. So in order to answer these questions, what Pcori did was, Pcori funded the development of its own research network. This research network is called PCORnet, or Patient-Centered Outcomes Research Network. The development began in around 2013. So kind of think of PCORnet as like a vast network of networks. It is basically a collaboration of several networks basically a collaboration of several networks that support research using health data collected in the course of care through electronic health records, through claims data, or directly from patients as patient-reported outcomes. There are more than 100 health institutions that are part of the PCORnet, and this is across the US. So due to this PCORnet, this is able to harness huge amounts of data, health data, and patient partnerships. Also, PCORnet is considered a DRN, or a distributed research network. So what it means is that each of the organization's data stays within the organization itself. And each organization, they respond to a common question based on their data. This makes clinical research faster, easier, and cheaper. I'll go into more detail about how this is achieved when we talk about PCORnet data. So as I mentioned, this network of networks, that is PCORnet, it's a tightly integrated partnership of 9 clinical research networks, 2 health plan research networks, and 1 coordinating center. So this clinical research network, these networks, they consist of healthcare systems like academic medical centers like Ohio State, Michigan. It could be hospitals, it could be a federally qualified health center, or any integrated health delivery system. One of the clinical research network is called PaTH, and Ohio State is part of the PaTH network, and that is how they become part of PCORnet. Then the second kind of research network, this is health plan research network. So PCORI funds 2 major US health plans. They are HealthCore, which represents the Anthem Research Network. And then other one is called PracNet, which is a partnership between Humana and Medical Outcomes Management. So through this health plan research networks, PCORnet is able to leverage claims data. Through the clinical research networks, PCORnet is able to leverage the electronic health records that are in place in all of these organizations. Then the third arm is the coordinating center. And the coordinating center is a collaboration between Duke Clinical Research Institute and the Harvard Pilgrim Healthcare Institute. So they also serve as the central hub for the network, bringing the diverse PCORnet network institutions and all these patients together through shared communications, meetings, initiatives, etc. All right, so I think I advanced to the next slide. So this image shows, this one shows how we are part of the PCORI consortium. So Ohio State is part of the PaTH network, which is one of the clinical research networks in PCORnet, which is the distributed research network of PCORI. So that is how OSU becomes part of the PCORI-PCORnet consortium. So here, what I'm representing is all the members in the PaTH network, which is one of the clinical research networks. So our partner sites are, there is Johns Hopkins, Temple, Pittsburgh, which is the lead site in the PaTH network, Penn State, Michigan, Geisinger, and Ohio State. All right, so that is it about the network. This was a very brief introduction into the network. So now that we have talked about the network, I think we can go and take a look at the data and see what makes PCORnet faster, easier, cheaper, what makes it unique. So as I mentioned before, PCORnet consists of almost 100 different institutions that are spread out all through United States. So the health data, record data that is generated at each of these institutions, they are stored within their electronic health records. Now this electronic health record, it could be Epic, Cerner, or even a locally developed system if it is a small institution. So at OSU, for example, we use Epic here. Michigan uses Epic, but Pittsburgh, I think, uses Cerner. So what this means is that the data is stored in different structures. The data elements might be defined in different ways, in unique ways at all of these different institutions. So asking a question and getting an answer from all of these institutions in a uniform way, it is always very, very challenging. To overcome this, what PCORnet did was they established what is called the Common Data Model, or the CDM. So this was something that was that PCORnet came up with. So what they did was they organized the data into a very standard structure. Each of the member site in each of the network maps their local data into the same consistent format. So at OSU, we pull the data from our Epic and we pull it out and we put it into this very structured, common organized structure. And each of the member site does this. So this means that there is a PCoriNet CDM at each of the member site which has data in a very similar format. Hence, this platform enables rapid responses to research-related questions. And this also enables, it allows analysis across many different sites. You can actually push one simple query to each of these sites and they can all run the query at their site, and then they can push the result back to PCoriNet. So this allows that rapid response. No one has to modify the query to suit their particular EHR because everything is common, everything is standardized. It can run on one single query. Then how is the quality of the data that is in this common data model ensured? So this is something that the coordinating center does. The coordinating center, they maintain this data model. So they maintain the quality of the data. They ensure the data quality for this research network. And how they do this is through a process called data curation. So what they do is the data curation, it happens every 4 months, once every quarter usually. So at that time, what we do is we pull the data from our EHR and put it into this format. Then the coordinating center, they push a data curation process to us and we undergo this process. It's a very rigorous process where the data is checked, verified, and checked for any discrepancies. And they also check if we are following trends and patterns over the years. And if everything looks good, then the data curation is approved. And that data, it is logged and it is used as the PCoriNet common data model for the next 4 months until the next data curation comes. And this process, which is done every quarter, it ensures that the data quality is maintained. So for those 4 months, the data remains static. So there is a refreshing of the data at least 4 times a year that happens. All right. Then OSU PCoriNet CDM is a coded limited data set. A coded limited data set, it means that all the data in it is de-identified, but coded limited data set, it allows for actual dates and actual zip codes into the, they are retained in the CDM. We also have patients who are 90 years old and above in the CDM. This is something that is possible only if it is a coded limited data set. So basically, research data, it can be broadly classified into 2 categories: identified data, which is PHI data and which needs an IRB approval. And the second one is the de-identified data. And a true de-identified data, usually in most circumstances, de-identified data does not need any IRB, but there are certain circumstances when de-identified data might also require an IRB. So the de-identified data again can be classified broadly into 3. So there is a true de-identified data set. This will not contain any identifiers. So MRNs, names, any IDs, they are all de-identified. There will not be any actual dates. The dates are all shifted either to the front or to the back. And also it won't have any zip codes in it. Also the population above 90 and above is also removed from a true de-identified data set. And like I mentioned, a coded limited data set, it retains dates, zip code, and also it contains patient population above 90. Then the third one is just aggregate data, which is just the count data. It could be a simple count of the cohort population, or it could be count data that is stratified based on age, sex, ethnicity, race, or other data elements. So I mentioned that in most cases, de-identified data, it does not need an IRB, but there are certain circumstances in which it needs an IRB. So the thing is that for de-identified data, there is always an associated threshold count. any count data or de-identified or coded limited data set that falls below this threshold, they cannot be delivered without an IRB approval. Example, you are looking for a cohort of patients who has a rare disease, and we found a certain number of patients at Ohio State. Say, for example, this number is 5. If the threshold for that data is above 5, we will not be able to provide that count to the requester. We will say that, hey, you need an IRB so that you can get this data. For the OSU Pcori data, the threshold is 11. So anything 11 and above, we can provide you. If you're requesting data directly from the EHR through an honest broker, the threshold associated with EHR data for Ohio State Wexner Medical Center is 25. So you will not get counts below 25 when you are requesting de-identified data directly from EHR. But through PCORnet, you can go down as far as 11. All right, now let's see how this data is structured into the CDM. So the basic table, it is a demographic table. So we have a demographic table that has a patient ID, which is a de-identified MRN, the birth date, which is the actual birth date of the patient. Then there are the other elements like sex, ethnicity, race, sexual orientation, and some other details. This demographic table can then be linked to all the other elements in the PCORnet CDM. So it is a very simple structure. And these tables, as you can see the name, these tables contain associated data, which include encounter details, medication details. The medication details can be prescribed medications, or medications that have been dispensed, medications that have been administered, then vital data. There is diagnosis and condition details, death details, if the death data is available in our EHR, then who the provider is and some details associated with the provider, procedures, all procedures that happened, what kind of procedure it was, the CPT code, the dates of the procedure, lab results, what the lab name was, what the Loeing code or the lab ID associated with it was, the results, actual results, all of these details are available in the PCORnet CDM. So this is a very simple structure, and this is implemented at all participating sites. So the simplicity comes from PCORnet determined what all elements might be the most useful for a quick snapshot of patient history and selected those to create this structure. This is an evolving design, and every few quarters, elements are added to this, or some of the elements are sometimes deprecated if they feel that there is not enough need for that element in the CDM. So there are only 21 tables in the PCORnet CDM right now, and these are all classified very rigorously into encounter details, diagnosis details, medication details, etc. So you can you can find the details about this patient based on this patient ID. The patient ID is in all of these tables. So it's very easy to retrieve the data as opposed to retrieving data from our EHR, which is usually Epic's Clarity or Computable database. So if you're thinking of pulling data directly from EHR, there are 16,000 tables in Clarity. So the data, there is a vast amount of data in it, and all of this data is spread out over these 16,000 tables. So what PCORnet is essentially doing is trying to pull all the most important or the most often requested data into this very, very simple structure. So right now, we pull data from Clarity into this, and we have data from November 2011 onwards. That is when Epic went live at Ohio State. We do have some historic data prior to that time period, but it is not extensive. All right. Okay, so this represents the current PCORnet CDM at Ohio State. This is data that we pulled on April 14th, 2021. So as you can see, we have 1.36 million patients in our demographic table. And we have data associated with all of these 1.3 million patients in our CDM. So the next curation will happen sometime around July. So till July, this is the data set we will be querying with to respond to any queries. So the one that you saw previously, that was the data set that is available in the local level, that is the OSU PCORNet level. Then if we go on to the network level, like I mentioned, OSU is part of the PaTH network, which is one of the clinical research networks of PCORNet. So PaTH has all of these member sites. There are 7 member sites. So if you want to request data on a network level, this is kind of a sample of how much data you could potentially query based on the network level. So Pittsburgh, all of this. So there's almost a 14 million patient population that is available in the network level, that is the PaTH network level. It might come in handy if you're trying to do certain kind of research which needs, say, a larger African-American population. When you look at the data, you can see that OSU data is predominantly white. But if you look at certain other sites, you can see that, say, take Temple, for instance, you can see that Temple has a high population of African-American and other minority population. So it might be useful in those cases to collaborate with that site. And you have the ability to do that through the PCORNet PaTH level. If we go one further up and go into the national level. So this is, I hope you can see this. So this is how the data is spread out. The data available in PCORNet is spread out. So you can see that we do have a concentration of patients from the West Coast, and then we have in the East Coast, down south. So this is all potentially, any researcher could potentially leverage all of this vast population for their research questions. All right, so now we have all this wonderful data. How do you leverage this? So making a request is free, and you can make this request in the national level, in the PaTH level, or in the OSU local level. Making a request is free, but there is a fees associated with retrieving the data, and users are they are encouraged to assess the suitability of PCORNet infrastructure and estimated cost. If you want to say you are going to submit a grant submission, and you're going to say that, hey, we will leverage PCORNet data for this grant. At that time, talk to someone in PCORNet and try to get a cost estimated cost for how much your research might cost, so that you can include that in your grant submission. So if you want to request national level data, aggregate count data, you can put in a request for aggregate count data in the national level, in the network level, or the local level. You do not need any IRB as long as it is above the threshold. In the national level, the PCORNet what is known as a PCORNet front door team, they will work with you to prepare a cost assessment for any use of the PCORNet resources. In the network level, the team from Pittsburgh, that is in the PaTH CRN, they will work with you to provide you a cost estimate. If you're only interested in OSU level data, just reach out to us and we can provide you an estimate and let you know what we can provide for you. So aggregate data, you do not need any other documents. You just need to submit the request. If you are requesting de-identified data set in the national or network level, you will have to sign what is known as a data use agreement or a data sharing agreement. And once that, only after that, you will get that de-identified data set. Here at OSU, you can request any data, any de-identified data that is currently present in our OSU CDM. So all researchers at Ohio State Wexner Medical Center they are approved to request this data. That is how our IRB is written. So you can request this data. If you are interested in requesting this data, just reach out to us and we can talk more details. So the how to request this data. In the national level, you can find the link on the PCORNet website. It's their contact us section. If you go there, you can put in the details about your study details, who you are, those kind of details, and someone will reach out to you. In the PaTH network level, there is a PaTH network website, and researchers, there is a data request form in there. So you can click that and enter the your request and details that you need. And if you're interested only in the local OSU data, there is again a research request form in the BMI website. It is called the Pcori data request form. And you can click that and put in the request. If you can remember where all of these details are, we have a u.osu page, u.osu.edu/Pcori. All of these details are in there. Or you can reach out to us at pcori@osumc.edu with any of these questions, and we will get back to you. I hope that is helpful. All right. So the next section that I wanted to go into was just to show the scope of this PCORNet data, this WAS network, how it can be leveraged. So it can be leveraged for a wide variety of studies like feasibility studies, computable phenotype validation studies, any studies that require linkage with a patient-reported outcome or survey results, a registry that's out there, clinical trials. So let's take a look at some of the studies that we have taken part of that belongs to each of these categories. So the first one is a feasibility study. This is what we get most of the requests for. So it's just feasibility for conducting a research study. Could be for site selection for a clinical trial. So for example, someone wants to know an acute kidney injury feasibility. They want to know if a certain site is, it is feasible to include that site in a trial or a retrospective analysis study. So the first thing that needs to be done is when you put in the request, there needs to be a study design. You have to define the inclusion and exclusion criteria. So when you put in the request, you are saying, hey, my cohort is patients with AKI. So define AKI. How are you going to define AKI? Provide us a list of ICD codes that you want to be included as AKI. Then any other conditions like age at diagnosis, the date that you are interested in. Are there any other exclusion criteria that you need to apply? So those kind of details. Once we have those kind of details, we can easily pull the count of patients, and we can stratify it by, age, gender, race, ethnicity, and we can also pull the comorbidities if you are interested in those kind of things. So this is what we get most of the requests for. The next kind of study that PCORNet that has come through PCORNet is validation study for a computable phenotype. So computable phenotype. All right. So computable phenotype is you can. So you are writing a certain query against the EHR, and you are pulling the criteria based on fields like diagnosis codes, medications that might have been prescribed, the conditions that might have exist. So all of these are put into a code, and this same phenotype, this computable phenotype, is then run at all of the different institutions. So since the PCORNet structure is the same, it is easy to run the same phenotype at all of the sites. So what we did was, one of the studies that we took part for the CP validation was identifying there was a CP based on diagnostic codes and encounters. And we initially, it was for a nephrotic syndrome study. So we initially ran this nephrotic syndrome computable phenotype against our CDM. And it pulled a lot of patients. There was a patient cohort population as well as a control population. And in order to validate this, what we did was we randomly selected 50 patients from the cohort and 50 patients from the control group. And an IRB was put in to access their actual MRNs and MRNs. And these MRNs were looked up from the EHR, and chart review was done to see if this computable phenotype actually pulled the right patient population. So this is one kind of study that we have taken part in. Then another are linkage studies. So there have been different kind of linkage studies. It could be linking a cohort study to a patient-reported outcome, surveys, registry. So one of these cohort studies, what we wanted to do was we wanted to identify. This was for a heart failure cohort study. So we wanted to identify if patient-centric factors important to heart failure patients, and also determine whether family support or community support, social support, or great support from their healthcare team, whether it would lead to improved outcomes for heart failure patients. And it was based on a model called the chronic care model. And based on that, what we did was an HF phenotype, computable phenotype was created. This phenotype was run against the CDM, and we identified all the potential patients that were in the CDM. And there were around, I think, 2,400 patients that we identified from the CDM. And IRB was put in that provides us the ability to contact these patients. 2,400 patients were contacted and asked, hey, are you interested in responding to a survey if we send you a survey and answer all these questions? Around 400, 500 people said yes. And the survey was sent to these patients. And we received response from around, I think it was around 432, something like that. We got that many responses. And these results, they have been collected and analyzed. And we plan to link these results to the CDM so that we can see that these patients, they have responded into the patient-reported outcome for these questions. The other study, this is also similar to, this is also a linkage study, but rather than sending a survey and collecting the data from them, this was linking the CDM into an existing registry. Registries usually have data that is collected during that transplant, but you don't have the ability to follow up the patients because at some point the data for that patient in the registry ends. So you don't have the ability to follow up the patient longitudinally. So there is that. Identifying that gap, PCORNet, the idea was to see if PCORNet data can be linked to an existing registry so that if someone wants to follow these patients longitudinally, they can be linked back to PCORNet. And since we are refreshing PCORNet periodically, you can get a longitudinal data section for these patients. So the registry selected for this was the TVTR registry, the heart valve replacement surgery registry. So all patients who undergo this, they are part of undergo this surgery in the United States as part of the TVT registry. And we also have a TVTR ID in our EHR. So we identified the patients from the CDM who underwent the surgery based on their procedure code. And based on the TVTR ID, we were able to link the patients into the TVTR registry. So this was, the linkage was completed, and there are talks about making this linkage kind of permanent so that, you always have the ability to go back and look at these patients. The last kind of study, this is the big one, so is clinical trials. Huge, large national clinical trials. And PCORNet wanted to see if how this WAS structure can be leveraged to conduct these large clinical trials. The first one that we took part in is called an adaptable study. So this was a large study, a multi-site study to determine whether 81 mg of aspirin or 325 mg of aspirin is more effective for patients with heart disease. Again, here the cohort was identified based on the computable phenotype. Then once these patients were identified and PCORNet found out which all sites have a healthy population, those sites were contacted, and sites who actually wanted to take part in the clinical trial, IRB was put in, all the contracts were signed, and then the recruitment followed all the protocols and regulations within each of the site, but under the PCORNet's guidance, which was what they were trying to do, which made the huge clinical trial go a little bit more smoothly than if there was no guidance provided in the national level. So the consented patients were enrolled into the trial, and what we do is when we enroll a patient into a clinical trial through the PCORNet CDM, there is a table in PCORNet CDM. It's called the trial table, and there is a trial ID in the table. So each of these patients who are part of any clinical trial, they will have a trial ID. So it's easier to follow those patients based on the trial ID in the future, even after the study ends. So this study is closed, and the results for this study was published this Saturday. So it was published in the New England Journal of Medicine, and I think what they said was they did not find much difference in using 81 or 325 mg aspirin. So it was suggested that they thought that people who are on 81 mg, there's more chance that those patients will continue to take the 81 mg, but patients who are on the higher dose might drop off after some time. So there is not much difference in using whichever dose is of aspirin to prevent patients with heart disease. So that was one of the conclusions. And we are taking, so 90 patients were enrolled at, I think it was like 93 patients were enrolled at Ohio State for this study. And we are taking part in other clinical trials as part of the PCORNet as well. There are around 3 clinical trials that are currently open and actively recruiting patients as part of the PCORNet CDM. And the final section I wanted to go in was just to provide some information about how the PCORNet, to provide the significance of PCORNet. So when COVID hit, early last year, and everyone wanted to get a snapshot of these patients, COVID patients, what were the conditions, that was plaguing the COVID patients, and all of these details. And at that time, CDC reached out to us and said that, hey, you already have this great infrastructure in place. Is there a way to leverage this and try to get some information of these COVID patients quickly, immediately, rather than starting from the beginning? So almost all of the sites, they were able to respond in like 2 or 3 weeks. Since we had this PCORNet CDM in place, all we had to do was try to narrow down the CDM's scope. So for us at OEC, what we did was we limited it for patients who had encounters starting from January 2020, because we thought prior to that, there was not much chance of patients who might have had COVID. So from 2020, whenever CDC would put in a request, we would refresh that part of the CDM and we would get all the data and we can respond to the queries. In the initial few months, there were certain hiccups because usually the data that comes into the CDM, it is based on diagnosis codes, medications, and these kind of codes, these are all billing codes. So unless a patient is discharged from the hospital, it will not come into the EHR and it will not come into the CDM. So we wanted certain other details like lab results, which would get updated quickly, or if there was a flag for COVID patients. So initially we did based on that, but then later we discontinued that and we were pulling patients who were just coming in for an encounter. And the query could pull the patients based on their diagnosis, medications, lab results, and those kind of things. So this was immediately set up, and we are still continuing to participate in this. Then the second one was in March, April, at that time, hydroxychloroquine, it was thought that it might help prevent infection in healthcare workers, and we wanted to test that out. So a healthcare worker registry was set up, where any healthcare worker within anyone who works in the healthcare field, it could be clinicians, physicians, nurses, other technicians in the hospital, or people who are working in the hospital, it could be the janitorial staff, everyone, they had the ability to register in this healthcare worker registry. And if they wanted to participate in a clinical trial for the hydroxychloroquine, that was quickly set up in the initial months when the pandemic hit. So those were some of the things that we did as part of the COVID response. And that is all I have for you. Any questions? I will stop sharing.
Hey, Janina,
there was
a question. Oh, yeah, go ahead.
Oh, yeah, I think we were saying the same thing. There's a question in the chat.
Oh, sorry, I couldn't see the chat.
Yeah, I don't know. Yeah, it's hard to see it when you're talking, but there's a, yeah, can you see it now? It says, what is the magnitude of data pooling costs at the PaTH and national level?
So I don't want to provide an actual cost because sometimes people get sticker shock when they see these prices. So what you have to understand is when you are requesting data at the local level, that is OSU level data, the cost involved is only the per hour fees that is involved for the analyst's effort to pull the data. But when you're requesting it at the national or the PaTH level, there is also something called the network access fees. And there are the fees associated with each of the analysts, each of the PIs, and the other members that are part of each of the network. And it depends also on the complexity of your query. But I don't know, Soledad, is it okay to say it would be upwards of 10K for a simple study?
Yeah.
Yeah, I mean, I don't want to scare people away or anything. It depends on the study.
Well, there is a lot of work, a lot of people that have to get involved. So, yes.
Yeah. Because it takes a lot of effort to, usually in the initial stages, to define the study and the study design. It takes a lot of effort and the part of the people. Yeah. It would be, I want to say, I have seen certain studies from 8K, but those were very simple studies. But we have also seen studies that goes upwards of 20K.
Well, it's pretty commensurate with how much you need to pay if you're going to go after CMS data or other types of data sets like that. It's not free. So I have a question for you. How do you do feasibility? Like, how do you check if you want to do a certain study and you want to see about numbers, how many you're going to get? Like, if you're planning to go for a data set in your proposal, is there a way that you can check feasibility of it?
So feasibility right now, if you want to check the feasibility just at the OSU level, just reach out to us and we can pull the counts for you quickly. It is what we do is it is charged at the rate of 120 per hour. But usually these count, since the structure is very simple, it won't take much long to pull the count data, unless you have a very complicated, criteria for pulling the counts. So you can reach out to us, and in that data request form, you can put in the request, and we can provide you the count.
Okay. Yeah, and that's something that probably could also be covered pretty easily by a CCTS voucher.
Yes, it is. Yeah,
especially if you're planning to do it for a study proposal, and you can get those costs covered through there.
Yeah, and let me tell that the CCTS voucher, I think it's for like it is 3,500 per PI. So usually for if someone wants to request data, the bigger data set like the de-identified or the coded limited data set and all of the data elements, it will take more time, but usually the CCTS voucher can cover that data. Rarely have we seen a request that goes above the CCTS voucher amount, because it doesn't take that many hours to pull the data from PCORnet. Of course, we need the resources to do that. If there is a national study going on, at that time, it might take some time to fulfill the request. But per number of hours, it doesn't take that long. And also, when you put in a request, please be mindful of your study design. Don't ask us for the entire PCORnet CDM, because we do get requests for like that. Can you provide me all the data that is in your CDM? No, we cannot. Please don't ask us for the entire CDM data. Just keep some filters. You need to have some kind of study design for your study. And also, without an IRB, this is a one-time data pull. So once we provide the data to you, we cannot supplement this data with even an additional one single additional column. Or if you want to tweak your study and change your criteria, we cannot do that. Once we provide the data to you, that's it. So make sure you get your study design exactly what you want. We can always discuss and finalize a study design before we actually pull the data and deliver it to you. This has, this is where usually people might think this is what I wanted, but once they see the data, they realize, no, that was not what I wanted. I wanted something else, and my criteria needed to be further filtered out. So those are things that we cannot do once data is delivered. So that is one thing to keep in mind when you are putting in a request. I mean, if you have an IRB and unlimited amount of funds, it's okay. We are always happy to work.
Is the effort to pull the data at the national level, is that through you, like locally, or is that then we need to actually pay for time at like the coordinating center?
So that would be at the national level when you are requesting a data. Usually what happens is the coordinating center, that is Duke, will reach out to you and they will work with you to create an estimate. So they actually, there is a data analyst team at Duke. They will actually write all the queries and they just push it to all of the research sites. So all of these 100+ research sites, and the research sites have the right to run the query and deliver the results or just reject the results based on any limitation they might have. So all of that would be included in the cost estimate for the that PCORnet provides you. So every year we get at least one query a week. I want to say at least one query every 10 days from the national level. And we respond to these queries. So this is included in the PCORnet funding. We respond to all of these queries and we provide the results to the national PCORnet level. And if there are additional studies that fall over that certain specific number of queries, at that time PCORnet will work with the researcher and see how it needs to be estimated. And for if you're seeking additional data, if you're not seeking feasibility data, count data, you actually want to collaborate with certain sites and you want to get this actual data set. At that time, you will work with the individual sites and you will need to sign all the contracts and the data use agreements, and there would be a separate budget for it at that time.
Okay, thank you very much, Nina. Are there any other questions? Group.
And if you have any questions at a later point, please feel free to reach out to us. You can email me directly, or you can email the pcori@osuMC.edu, and we can always chat one-on-one to discuss your studies in more detail.
Great. All right, well, thank you very much, Nina, for your presentation. It was great. And this will be recorded and posted. And I think I'm going to stop recording now.